This presentation this morning isn't a grand rounds. I'm not doing 2 grand rounds in 1 month. I'm not that much of an overachiever. But this is an article that came out in Peds in Review not too long ago. We see a lot of kids with nocturnal enuresis, and it's a big problem. It's very stressful for families, and so I wanted to present this article because I think it helps if you have some hard evidence and you have some literature to support why you're telling parents that these are the things they need to do, especially when the first thing they need to do is not give a medication. It helps to be able to say, okay, the problem that you're having with your child is very common. It happens in this percentage of children. This is what we know works. It works this percentage of the time. I think that evidence helps parents, especially when they're very stressed out about what's happening. When there's bedwetting involved, it's a big deal for everybody in the family. And so it helps them to understand that what's going on with their kid is common, and when you can say, this is what we expect to work, this is how long we expect it to take to work, it helps a little bit, I think. Okay, so questions to start with. Pop quiz. Anybody want to venture a guess at what percentage of kids have bedwetting by age 6? Anybody read the article? Who thinks it's less than 5%? Anybody? Less than 10%? Less than 20%? Okay. So it's about 15%, 10 to 15%. And so what happens is you can tell your patients to help them understand, how many kids go to your kid's school. Do you think it's more than 100? Well, probably 15 of those kids will wet the bed. And so it kind of helps them put into perspective how common the problem is. And then there is still bedwetting that persists into teenage years, and it's about 1 to 2%. So over the years after age 6, the incidence decreases by about 15% per year. And so we still do see it. It's much less common in older kids. But you may have a parent come in and say, oh my God, my son is 12, he still wets the bed. What am I going to do? I can't believe this is still an issue. And so you can tell them, yeah, unfortunately it does still happen in that age group too. Okay. So we won't go through a whole case, but I wanted to talk about what's important in the history taking and in the physical exam for a kid with bedwetting, because we've all seen one in clinic. And so in the article, they talk a little bit about how we have lots of time constraints as pediatricians. We can't take an extensive medical history every single time a patient comes in, but there's some important points to hit when you have a kid that comes in with bedwetting. So she's 5. She's never had a dry night. She doesn't have accidents during the day, and she doesn't have any past medical history. So what else do we want to know about her history of bedwetting?
Any other signs that might be indicative of diabetes?
She's not super thirsty. They haven't noticed that she's having weight loss. It's a very, very good point, because we have had a kid in clinic who, I was going to talk about her later, but I'll spill it now, who was bedwetting and was started on ditropan, which we'll talk about later if that was appropriate or not. And she ended up having 5 or 6 UAs at her PCP's office that were positive for glucose. And so they just kept repeating it and repeating it and repeating it. No one ever got an A1C, no one ever got serum glucose, and she came in with DKA. So very, very good point.
Is that someone who was never?
I can't remember if she's or not. What else?
What have we tried? Like limiting intake, water before bed.
So she drinks a glass of milk before bed. It's a small glass, but she doesn't drink excessively before bedtime. But other than that, they haven't tried anything else.
Does she wake up after she wets the bed, or do the parents monitor?
No, she wakes up after she wets the bed.
Family history of bedwetting?
So dad has a family history of bedwetting. until he was about 10 years old.
What are her sleep habits?
She goes to bed by 9. She sleeps well. She sleeps very soundly, they say. She's hard to wake up. Healthy, never had a history of UTIs, no neurological issues, perfectly healthy little girl except for the bedwetting.
Sacral lipo. Sacral lipo. I don't know if you've done physical exam.
No, we'll get to the physical exam too. I think we covered everything I was trying to cover.
And do they have her wearing pull-ups at night as compensation?
And also another important thing is the bowel movement pattern. So she has a stool every day and she's not constipated, and parents have seen her stool. So that's something that you need to ask, because they'll say, well, they go to the bathroom 10 times a day, but if they've never seen the stool, they don't know if it's hard. They don't know if they're really pooping or not. But we covered most everything. So how many nights a week does it happen? It happens every night. She's never had a dry period. That's really important. She does drink in the evening before bed. There's a family history. I think we covered every single one of these. She's not having problems controlling her urine during the day either. Family history. Sleep issues. We said that she's hard to wake up, but that's it. We didn't talk about this. So she's bothered because she can't go stay at her friend's house. So that's an important part of the history too, because you want to know how much problem it's causing for them. And if it's not causing a problem, if they're really not worried about it, you still need to intervene, but you have to understand that, if the kid's 5 and she's, doing her own thing, she's not really bothered by it, then you may have a bigger issue in trying to control it. Like that. And then stressors in life, there's nothing going on. Parents are married, they're not having any issues. There's no new siblings, you might want to ask about that. They haven't recently moved, changed schools, and things like that. Probably less important in her case because she's never been dry, but if you have a kid who suddenly starts wetting the bed again, then that's a big issue that you want to investigate. So her physical exam. What is, we don't have to go through the whole thing. We can talk about abdominal exam, genital exam, and then the neuro exam. Her vitals are all stable. On the abdominal exam, anybody want to venture what we need to look for? Students? Residents? No suprapubic tenderness. Sometimes if you're dealing with a urinary retention issue, you can have a big palpable bladder if they have some kind of neurogenic cause, or if they have posterior urethral valves and they just have a big post-void residual. Or if they have a UTI, they might have suprapubic tenderness. You do want to do the genital exam and look for labial adhesions. If they're always wet, they might have an ectopic ureter, so some area that's draining urine all the time, or they could have chronic changes on their skin because they've been wet all the time. If it's a boy, you might look for urethral meatus stenosis. Talk about their urine stream, whether they have a strong urine stream or not, because they could have posterior urethral valves as a cause, and they may have a weak urine stream because of that. And then Dr. Habib said a sacral dimple. So make sure you look at their back. Look for a cause, a neurologic cause. Do they have any evidence of spina bifida, like a lumbar tuft of hair or something like that? And then in this article, they recommend testing the sensation in the perineum to make sure that there isn't a neurological deficit there. I think that's something that we don't normally do. Pretty easy to do if you're going to look down there anyway, just to rule that out completely. And then you do want to do a neurological exam on them and just make sure that their strength is symmetric, they don't have any signs that they could have a neurological cause. This article breaks down the different types of enuresis. So they talk about primary monosymptomatic nocturnal enuresis. Long name, simple explanation. Never been dry before. So these are the kids that have wet the bed forever and ever. and they don't have an underlying cause. So they don't have some neurological issue, they don't have like a bladder or renal issue that could explain their problem, and basically, you've ruled out some other causes and they just have plain enuresis. Lots of possible issues, we'll talk about these. Familial, so kids who have a parent who wet the bed, 50% of, if there's a parent who wet the bed, 50% of that parent's children will also wet the bed. So it's super common in families. We don't know why. Sleep arousal issues are also a problem because across the board, parents will say that their kid is just hard to wake up in general. Like, they just sleep so sound, they're like a rock, and some of them wake up when they wet the bed, some of them don't wake up at all, and you just find it in the morning. And then some kids will have nocturnal polyuria where they'll actually have a higher urine volume at night, and so that creates the issue. And then in the small subset of kids, they can have overactive bladder. Non-monosymptomatic nocturnal enuresis is everybody else who doesn't fit in the primary category. So kids who've had lots of UTIs, kids who wet diurnal enuresis where they wet themselves during the day, and then known anatomical structural abnormalities or neurological dysfunction. And then secondary would be a person who has been dry for 6 months. So that's where that question of have they ever been dry before comes into play. And if they have been dry before for at least 6 months, then you can categorize them as secondary nocturnal enuresis. So a lot of times we'll come in and it'll be like a 4-year-old who has started to wet the bed again. And some people will say a 3-year-old has, they were potty trained, but really this is more the kids who've been dry for a longer period of time and now they're wetting the bed again. Okay. We talked about a lot of this stuff already. So 15%, 10 to 15% will still wet the bed at the age of 6, 1 to 2 by the teenage years. Much more common in boys than girls. For some reason associated with ADHD. Don't know why. I don't know if anybody's ever even explored that. And then up to half of kids with a parent who wet the bed will wet the bed themselves. So this is a chart that's from, I've adapted it, but it's from the article. And so they just talk about a rapid screening questionnaire. It's not a validated questionnaire, but it's just to save you time and to ask those pertinent questions. We talked about all these. Have they been dry? Are they urinating on themselves during the day? Are they constipated? Have they had a stressor? And if they haven't had any of that stuff, then you can feel comfortable saying that it's most likely just primary monosymptomatic nocturnal enuresis. If they're wetting themselves during the day, then we'll talk about it a little bit later when we talk about how to treat. Then that is usually just an issue of them taking time out to go to the bathroom, or a school problem where they're not given time, or they're just playing and they're not spending time enough to recognize that they have to void. So UA is the only hard and fast recommendation for these kids, so you have to get the UA. You need to know if they have a UTI, if they have proteinuria, what their specific gravity is, to know if maybe they have diabetes insipidus or some other reason for a large urine volume. And then the other part of it is avoiding and fluid intake diary, which we all know it's next to impossible to get parents to do stuff like this. But if they're really bothered, if they're having a big upheaval at home about bedwetting, then it may be easier to convince them that they need to do it. And so while they're home, they need to measure the urine volume with the little hat that fits in the toilet, and then write down what they drink. And it helps for them to write down how much and what type, because that'll help us understand what their bladder volume is, what time of day they're drinking the most, and if that's contributing to their symptoms or not. So it always helps to know what's going on at home. And even when you're taking a history, like for the students, it's helpful to break it down. Like sometimes you can ask the parents, well, what do they eat or what do they drink? it's helpful if you say, like, what time do they come home from school? Do they eat a snack and drink something after school? Do they go play? Do they come back and drink after school? So sometimes you have to actually break it down hour by hour and get them to give you a really thorough history that way.
Sarah, do you have the parents weigh the pull-ups like you do with little babies?
Take this tiny scale home and weigh the. You can ask them, like, did their, were their sheets soaked? Did you have to change their whole pajamas? I think probably in most cases they would. Do you have one of those pads underneath their sheets? Like, there are questions that you can ask to help quantify how much urine there is, but they usually, I don't know, people tend to overestimate how much of any fluid there is. And so when we get the voiding, if we get a voiding diary, we can help estimate how much bladder volume a kid is expected to have. And so that can help us understand if they have like a large residual volume, if they're voiding more than expected, if they're voiding not as much as expected. So when we talked about nocturnal polyuria, where they're just producing more urine at night, their estimated bladder capacity will be 130% of what's expected. And then if they have a small capacity bladder, their max void will be about 50% less than expected. Nephrologist, is that anything that you've ever heard of? Okay. 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 And so just to give you an idea, I just worked a couple out just so you know about how much you should expect them to void. And I guess, you could do this in the office too and just measure how much urine they have. So what do we do with it all? Parent comes in, they're ripping their hair out, they're changing sheets every night, they can't afford pull-ups anymore. A lot of our patients, or a lot of our patient population probably doesn't have a washing machine in their house. They definitely can't afford pull-ups. And so it becomes a real big stressor for them. And so I think everybody's probably heard of the bedwetting alarm. We've talked about treating with DDAVP, but I didn't know how a bed alarm worked. I didn't know what they looked like, what different kinds they were, so we'll talk about that. We'll talk about what's right and what's not wrong, but lower down the list of things you treat with. So first, when you're thinking about treating, you have to take away all the other stuff that's confusing about why they're wetting the bed. So are they pooping every day? Are they peeing when they need to pee? And how much are they drinking? So sometimes if we eliminate all these other confounding issues, then the bedwetting problem will resolve on its own. So if they're constipated, they need to be sitting on the toilet at a scheduled time, like after they eat. They need to be on a bowel regimen. They need Miralax or stool softener. And we need to know really how much they're voiding and how much they're drinking. And then we talk about lifestyle modifications. So can we say this kid is drinking too much at night, go home for a week, and try to not drink as much at night? Are they sleeping in a normal pattern? So these kids that are really hard to wake up, are they having a regular sleep schedule? Maybe we can try to tweak that a little bit. And then train them to go to the bathroom before bed and wake up, and go to the bathroom through the night if they need to. An issue with limiting fluid intake is a lot of times during the day at school, kids don't get to drink as much. And so when they come home from school, they'll want to drink a lot and try to replace all that deficit that they've made during the day. And so they recommend to do 2/3 of the daily requirement in the daytime, and then after school, the last 1/3. So they really should be able to drink at school during the day. And then only limiting intake an hour before bed. That just stresses how important it is to know what they're actually drinking, because before you say you need to limit what your kid is drinking, you need to know if they're dehydrated or not, and maybe they're not getting enough during the day. Okay. So the bedwetting alarm comes in two different styles. One is a mat that goes under your mattress or under your sheet, and it responds to moisture, and it has like an audible alarm. The other one is this clip, which actually clips onto your underwear, and it has a cord that goes all the way up and it clips on you right here. So, I don't know, that's weird to me. I like the mat. But they both have an auditory alarm, and some of them will have a vibratory alarm too to increase the chance that the kid will wake up. Regardless, you have to tell the parent, they have to get up too. They have to hear the alarm, get up, get the kid out of bed. You can involve the child in stripping the sheets and, cleaning themselves up and everything. But the parent has to participate. And so if you're using this alarm, you can imagine what's happening to everybody else in the house who hears the alarm. So this is a whole family issue. So poor kid, right? Clip this to your underwear and go to bed. But the bedwetting alarm is effective, and it's level 1 evidence. So remember, that's the highest level of evidence when there's a big Cochrane review about bedwetting alarms. So it does work. They are expensive. They're about $85 to $130 something on the bedwettingstore.com, which we have coupons in the clinic if anybody ever has a patient. We do have some coupons for this. So some patients may not be able to afford it. But there's really positive results. About 2/3 of patients will have a cure. And so what you should tell them is when they get the alarm, they need to use it every night. They need to be getting up at night with the kid. And they should use it until they have 14 consecutive nights that are dry. After that, they can do a trial and stop. If they have a relapse, they need to start it again. And it usually takes about 2 to 3 months for this to be effective. So it's important that you give them a good expectation. You're not going to take this home tonight and it's going to go off and then boom, he's cured and he's never going to wet the bed again. So you just tell them that the best evidence is for the bedwetting alarm. It works. It's going to take several months for you guys to get in the groove. He may have a relapse, but this is the best treatment.
So the alarm, you also have to educate the parents. The alarm is not to make them not wet the bed, but it's
Right.
to train them to get up at night and go to the bath, and so that they don't sleep so soundly all the way through the night. The alarm is very loud in my experience with one of our children. It wakes a lot of people. But even so, some kids will sleep through it. It'll be there buzzing away and kids sleep right through it.
Yeah, I believe that. What else was I going to say about the alarm? Yeah, so they still are going to have to get up, and then you should have them try to finish voiding, see if there's anything else left in their bladder after they wake up. This is it's such an important issue too to talk about, because we do sometimes see child abuse related to bedwetting, punishment related to bedwetting, and you just really have to tell your patients they're not doing this on purpose. This is a kid problem, and we've got to be part of the solution, not to punish them, because they don't understand. And there's a lot of immersion burns associated with bedwetting, where they'll just go to clean the baby up and they'll put them in hot water and they get really badly burned from that.
So the low-cost alternative to this is just give the parents an alarm. And the parents wake up at 2 o'clock every morning, get out of bed, go pick up the kid, wake them up, take them to the bathroom, and that's the cheap way to do it, but they're doing the same thing.
Without having to strip the bed.
Without
Yeah.
having to, yeah, hopefully.
And it's totally okay for the older kids that, they can participate in changing the bed, and they should participate in taking the sheets off and putting the sheets on and cleaning themselves up. So I think we see very commonly that people will use DDAVP for bedwetting. Sometimes in our clinic, the cost of the alarm, parent participation, kind of steers us toward trying this first, even though we do educate them that it's not the best first-line treatment. It is a first-line treatment, though, and so the tablet is preferred to the nasal spray, and I've seen the nasal spray used a lot, and that's related to complications with the nasal spray. It's about 30% effective. You should only limit their fluid intake about an hour before bed, because if you limit their fluid intake too much, then they can get hyponatremic. I'll give away my question at the end. And then, like any medicine, if you need to do some trial withdrawals after several months to see if they still need it, because you definitely don't want them on this if they don't need to be on it anymore. The other drugs that are talked about are anticholinergics and tricyclic antidepressants. So we've seen a lot of kids on ditropan. A lot of kids just diagnosed with overactive bladder that have never had any kind of urodynamic studies or anything. It's definitely less common in kids, and bedwetting is super common. So this is not a first-line treatment. If you have a kid that's maybe failed the alarm, failed DDAVP, you have concerns that their bladder volume is small, and you're really worried about overactive bladder, you should probably have them evaluated with some urodynamic studies to see if they really need to be on an anticholinergic. The other problem with anticholinergics is that the side effect is constipation, which can affect their bedwetting, and so you get into this cycle. So you really need to, if you're going to start this, you need to warn people about that. And the article recommends that we only use anticholinergics in cases where we have like really good follow-up in centers that are specifically trained in using this for treatment of bedwetting. The other one is TCAs, which I don't think I've ever seen anybody on, but also not a first line. There's only 20% success and 90% will relapse. So it's not the best option. And then the complications are what? So QT prolongation, right? Or poisoning, if you have a small kid who's taking this, you don't want that. So one thing the article did say was that in kids that have ADHD and that are refractory to other treatment, that this might be a good option. They didn't talk about why. I think overall in our clinic, we're either going to talk about bedwetting alarm, lifestyle modification definitely, and DDAVP. So this is busy, but this is a summary that you can refer back to if you have a kid, that has one of the different subtypes, so you can look and see what the first line treatments are, what the other possible treatments are. But the take home from this, I think, is the numbers, to tell people 15% of children at the age of 6 will wet the bed. 2/3 of kids who use the bedwetting alarm and really use it diligently will have a cure. If this doesn't work, we can use DDAVP, and that increases our chances to about 30% of, not bedwetting anymore. So an 8-year-old has been bedwetting nightly. Avoiding diary reveals that the max amount of urine voided during the day is 150 mLs. You are most likely to recommend what? So if you work out his bladder, expected bladder capacity, it's 270 mLs. Anybody? Bueller? E? Good. A 7-year-old boy has nightly bedwetting. His parents would like to implement behavioral and pharmacologic interventions. You counsel them to wait to implement these strategies. The historical information most likely to cause you to make this suggestion is, I have a typo. So both parents with primary monosymptomatic enuresis, he's diagnosed with ADHD, he's lack of interested in being continent at night, he's got symptoms of constipation, or he has symptoms of sleep apnea. I got this one wrong. I did it. So, it's actually his lack of interest in being continent at night. That's what they say. So I guess for him, there wasn't an explanation, but I guess I took this one to say that you could do some behavioral things. You maybe wouldn't do pharmacologic at this point. Just try to get him into the groove of getting up and urinating at night.
I would have thought D because
Yeah.
constipation.
I thought that
is something
too.
you'd fix
Yeah.
first.
That's what I said too.
Yeah. Yeah.
A 6-year-old has never been continent at night. Both he and his parents are interested in intervention to help him stay dry. He has no constipation, sleeps well, is performing well academically. Both parents wet the bed until they were 8 or 9. The intervention you are most likely to recommend is...
Go check the room, the body down there. And the track, wash.
I didn't put the answer on this one. I think it's Bedwetting Alarm. A 5-year-old has voiding incidents during the day and night and has never been dry. He has no skin lesions on the lower back and his neuroexam is normal. He has a daily bowel movement and has no bowel voiding incidents. His bladder capacity is 300 mLs. He sleeps through the night. You're most likely to recommend... This 5-year-old girl was continent day and night at age 3. She's now having bedwetting at night. She has daily bowel movements not observed by the parents. She sleeps heavily but wakes with a nightmare a few times a month. She's the oldest of 3 children with a 3-year-old sister and a newborn brother. On physical exam, height and weight are the 50th percentile. She has no skin lesions. She's talkative and fidgety during the exam and asked to go to the bathroom when the visit's finished. The most likely cause of her bedwetting is... So is she primary, non-monosymptomatic, or secondary? Secondary. Her brother's the reason for her bedwetting, so she's stressed about that, and so she's having some regressive type behavior. That's it. Any questions?
Sarah, would you describe, if you can, or maybe a nephrologist office, what's involved in urodynamic studies and what are those going to tell you?
So my experience, I did some urology. I thought that I wanted to do that in the beginning, but they put a probe into, I've never done one on a boy, I've done them on girls. A probe into the vagina, a little sensor, one into the anus, and they actually fill the bladder up to capacity and watch the bladder contractions, and it traces a wave on the computer analysis. And then if the patient is able to respond, you ask them when they feel the urge to void. And then when they feel the urge that they just can't hold it anymore. And then you let them void and you watch the contractions to see if they're appropriate, to see if their appropriate sensation to void is at the right volume for their age, I guess. Is that?
So the retrograde.
Yeah.
So not something you're going to do on an awake 3-year-old.
No, probably not. No. I can't imagine doing it on any kid. I did them more on adult patients.
Is it contrast, non-contrast? They just feel.
It's just saline.
About 10%, there's a 10% chance that they will outgrow each year, okay? So if the kid is 6-year-old, by the time there is about 50-year-old, there will be a 80 or 90% chance that, so there is 10% chance that the kid will outgrow each year. And also the treatment is like safe medication, so you have to definitely give some attention to the patients. Too much and immediately that can they will be not
How often do you think, if we have a patient on it, should we check their sodiums? Should we do it once a month or every couple
It
of
also
weeks?
depends on the fueling. So it's not just every give that fueling 2 hours before, so it's kind of on the sodium. But the next day, sodium may be normal. The patient has drive, okay, delivery, okay, because it's usually
So that's another counseling point for our patients. We need to make sure we tell them that it's not a benign medicine, that we really would prefer them to start the lifestyle modification, the bedwetting alarm before we start that.
The DABP though is a good medicine to use if they're teenagers and have to go for sleepovers and they're worried they're gonna wet their bed while they're in else's house. So you can tell them we'll do lifestyle modifications and everything else at home, but the nights you have to spend away from home, you can use this medicine. So maybe once a month or something. Because the problem is if you don't do that, especially as they grow older, then they develop social anxiety and have, kind of have other psychological problems associated with it.
The suggested approaches to treatment, having the parents wake the child up before they go to bed or waking them up in the middle of the night wasn't on the list. Is that something we don't advise parents, or is that something that's been shown not to be as effective as the other treatments, or specifically the using the alarm?
I don't know why they didn't talk about that, because they, in this particular article, they talked about the Cochrane reviews, they talked about the level of evidence, but I don't know if maybe that hasn't been studied. I would imagine that it has to have been. I didn't delve that deeply.
All the time, parents to try and avoid the episode was to wake up the child before they went to bed, or John mentioned everybody wake up at 2 o'clock in the morning and take the child to the bathroom, but I'm surprised it didn't make the list.
Should have looked into that.
I think there's probably a lot of parents who do that informally because it's just logical to do it, and it's harder to study, but it'll also have, it's wearing on you, as parents, and who get up tonight and does it disrupt your sleep, so that you can't perform at work in the morning, those kind of things. It's a difficult problem in families.
Especially the patient who have primary aneurysm and having the accidents during the day and letting that all the time. So in that case, we have probably also by the VC,